Fifth sound. Fifth sound. Fifth sound. سلام. سلام. Taste the sound. 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 Taste the sound.
priority issue. Just can be like in budgeting of mental health activities. So mental illness apparently contributes to very but we are not referring to other factors also remaining to the engagement of the community and in product. So this shows how the problem here is focusing on communication. There is a priority issue as a priority issue as can be implied in budgeting as compared to mental health activities. So mental illness apparently contributes also remaining to the engagement of the community and in product. So this shows how the problem here is focusing on communication. We need to really articulate verify. We have also image gap. The deployment of community health extension workers in private health setting. There is also specialized mental health hospital, which is known as Amale. And there are the issue as can be implied in budgeting as compared to mental health activities. So mental illness apparently contributes also remaining to the engagement of the community and in product. So this shows how the problem here is focusing on communication. We need to really articulate verify. We have also image gap. Deployment of community health extension work development. There is also specialized mental health hospital, which is known as Amale. And there are the issues as can be implied in budgeting as compared to mental health activities. So mental illness apparently contributes also remaining to the engagement of the community and in product. So this shows how the problem here is focusing on communication. We need to really articulate verify. We have also image gap. Deployment of community health extension work development. There is also specialized mental health hospital, which is known as Amale. And there are the issues as can be implied in budgeting as compared to mental health activities. So mental illness apparently contributes also remaining to the engagement of the community and in product. So this shows how the problem here is focusing on communication. We need to really articulate verify. We have also image gap. Deployment of community health extension work development. There is also specialized mental health hospital, which is known as Amale. And there are the issues as can be implied in budgeting as compared to mental health activities. So mental illness apparently contributes also remaining to the engagement of the community and in product. So this shows how the problem here is focusing on communication. We need to really articulate verify. We have also image gap. Deployment of community health extension work development. There is also specialized mental health hospital, which is known as Amale. And there are the issues as can be implied in budgeting as compared to mental health activities. So mental illness apparently contributes also remaining to the engagement of the community and in product. So this shows how the problem here is focusing on communication. We need to really articulate verify. We have also image gap. Deployment of community health extension work development. There is also specialized mental health hospital, which is known as Amale. And there are the issues as can be implied in budgeting as compared to of community health extension, whatever looks like the problem is also specialized in private and hospital, which is the Samana, and there are the issues needs were integrated as compared to communities funded. So
my name is Tanrat from University. I hold my BCC certificate from University. My secondary from KU. I will present my disorder and associated factors. People living in the town, the community-based study. I'm from my name is Tanrat from University. I hold my BCC certificate from University. Disorder and associated factors. He is representing outlines, background of methods and materials, results and safety, conclusion and recommendation and finally acknowledgement. As a background, post-traumatic stress disorder is a mental disorder occurring after trauma and involves intelligence, results, mood change, and hyperarousal, according to the American Psychiatric Association. Worldwide, post-traumatic stress disorder affects around 8 million adults. Mental health includes stress, relative disorder, is chronic disease, the second leading cause of disability. Complete affected population shows much higher post-traumatic stress disorder prevalence when we compare other group of population. Affected conflict, armed conflict in northern Ethiopia exposed civilian to severe trauma in 2021. The town experienced intercommunal conflict in 2021 and also 2022. Post-traumatic stress disorder prevalence and hyperarousal, according to the American Psychiatric Association. Worldwide, post-traumatic stress disorder affects around 8 million people. Mental health includes stress, relative disorder, is chronic disease. Incidence on post-traumatic stress disorder among conflict affected civilians in Ethiopia is a minimum post-traumatic stress disorder. was assessed by also social support scale. Some independent variables here is presented. Data analysis, statistical spaces, theoretics was used, and logistic regression. Here is the result. Overall, the prevalence of post-traumatic stress disorder among population living in the town during the war was 19.4% with this confidence interval. Which is comparable to Morocco, Morocco and Serbia, and lower than Ethiopia. Conduct on the southern part of Ethiopia and Nigeria and South Sudan. Significant predictors for post-traumatic stress some independent variables results presented. Data analysis, statistical spaces, theoretics was used, logistics Overall, the prevalence of post-traumatic stress disorder among population living in the town during the war was 19.4% with this confidence interval. Was a strong figure that comparable to Morocco, and Serbia. Lower than Ethiopia. Disorder. So this indicated heightened urgency for psychosocial constantly major pressure on traumatic recommendations. Paid for post-traumatic stress disorder prevalence among the Thank you. Thank you. Thank you. our cases, they are experiencing long hospitalization or repeated hospitalization, so it reduces the adaptive coping. Older caregivers face decline in health, reduced support, or higher distress, which leads to weaker adaptive coping. And physical abuse increases stigma and distress, which leads to undermine the adaptive coping. The other is maladaptive coping, where mean scores of 21.1, which was higher than studies conducted in Iraq, which was 18.3. In our study, high stress from frequent hospitalization symptom relapse leads to maladaptive coping, like withdrawal and avoidance. There are factors which affect the maladaptive coping. That is one of the factors which has a direct effect was psychological distress with 0.13 beta coefficient. That's the effect size. And also there are multiple factors which has indirect effect with maladaptive coping, like female sex, age, able to read and write, job loss because of caregiving, verbal and physical abuse, duration of illness, number of admissions, symptom relapse, and history of hospitalization were factors which have indirect effect with maladaptive coping. Burden and comorbid medical illness were having both direct and indirect effect, meaning the total effect with maladaptive coping. These negatives indicate all reduced maladaptive coping indirectly, they are increasing adaptive coping. Comorbid medical illness intensifies emotional distress, which leads to more maladaptive coping, or literacy reduces distress, or improves problem solving, which reduces the maladaptive coping. Older age, women or farmers benefit from better social networks, which may lead to more coping, less maladaptive coping. And the other might be because of frequent admissions may enhance caregivers' knowledge and resilience, which indirectly reduces maladaptive coping. But then distress strongly predicts maladaptive coping, while social support is a key protective factor. Our qualitative themes confirm that physical abuse, relapse, and financial strain heighten emotional exhaustion and push caregivers toward this avoidance, withdrawal, and disengagement. These are the final model, which contains both factors, which has direct, indirect effect with the red line where the positive, our outcome variance, adaptive and maladaptive. So it is the final model with the acceptable ranges. This table is a qualitative summary of qualitative finding. So there are challenges, and the challenges were categorized under three themes with from patient's behavior and illness. What the patient, the caregiver experiencing were feelings of hopelessness, mental exhaustion, loss of personal purpose or work, safety concern, violence and distraction, and self-harm were the behaviors from the patients. For example, one caregiver reported that will give up on yourself, became hopeless and despair. I often feel sad and so say to myself, I have no hope. This is what the experiences. The other is social exclusion from the community. For example, one schizophrenic caregiver were reporting that people or community are touching your wound. But I say to myself, I have to be strong. This is what they experience. The other is financial burden. Under financial burden, they reported that medication cost, transport cost, current tax cost of living were they under the economical cane. For example, one study participant reported that I finished my property. I have gone to as far as Wollo from Gondar and Shawarobit to get a solution for my child health. The other is the experience as coping, phase as spiritual, avoidance and withdrawal, advising and calming and social support were the themes. And for the phase and spiritual, prayer, religious rituals, and faith in phase were the common experiences, and leaving their home or talking with someone else were the avoidance withdrawals they used, advising patients probably the behavior is another experience they have, and try to get support from neighbors was another social support with respective things. As conclusion and recommendation, uh, having caregiver was having low adaptive copy compared to the general population. And our qualitative finding indicates that caregivers use both adaptive and maladaptive copy. And being a farmer, being a female, age, and long duration of illness, high number of admission have an effect with adaptive copy. Comorbid medical illness, caregivers literacy level, being a farmer, female, age, duration of patient's illness, and the number of hospital admission, history of physical abuse, job loss because of caregiving, symptom relapse, previous hospitalization were an effect on maladaptive coping. Furthermore, caregivers' burden and psychological distress have a direct positive effect on maladaptive coping, while social support was having direct negative effects on maladaptive coping. As a recommendation for healthcare professionals, we have to provide psychological support to caregivers, especially for those facing patients with symptom relapse or physical abuse. Address stigma in early stages of illness to promote adaptive coping, and for programmers, implement preventive mental health programs to strengthen caregivers' coping strategy alongside the patient care. For researchers, conduct longitudinal studies to examine how clinical variables influence caregivers' mental health and coping over time. Finally, I would like to thank for study participants, data collectors, University of Gondar, Mr. Jibu, who was my advisor during my thesis, and the Amara Public Health Institution. I thank you.
Thank you very much, President. So now I call upon some of you to take the stage and respond to questions and accept comments from the audience. Paradigm shift from positivism to post-positivism, including mixed method design. That is what however, especially the first presenter totally missed the quantitative component. I don't know the purpose of the qualitative part unless you present it here with the quantitative. So that is the big limitation I saw. Before I go to the audience, I may have some comments for you. Especially the first presenter, you said there is no national mental health strategy, or did you ask a mental health strategy for that district? Because it has to take the national mental health strategy and adapt it, or were you expecting it to have a mental health strategy at the district level? And I think at least you should have otherwise we are not able to say anything about the quantitative part of the research. Concerning the second presenter, post-traumatic stress disorder, among people experiencing trauma is that people exposed to trauma or experiencing. It is very different. To say experience, a person should have himself a trauma directly. When you say trauma exposed, we all can be exposed in some. You may be directly traumatized. You may witness someone being traumatized or killed for that matter, or you may even see via the mass media. That is also a type of exposure. So exposure and experience are different. So I think it should be exposure rather than experience. እንደዛ ስለሚል እሱ መስተካከል አለበት ብዬ አስባለሁ። So and the last presenter, that's very good, but as it is a parallel mixed methods design, the qualitative and quantitative should be integrated. When you present the findings, they have to be integrated. And would like to see the essence of the phenomenon, because this is a lived experience, the what and how of the experience and the common experience for all the study participants should have been mentioned, because it is parallel. When you say parallel mixed method design, the data collection, the analysis, the right up take place together and should be integrated, compared and contrasted. And all the variables included in the quantitative should also be part of the qualitative in parallel mixed method design. Since this I go to the audience for questions and comments. You can direct your questions to specific presenters.
Thank you all the three presenters. I just want to comment on some of your presentations. The first one is input. When I see your background, your references are not recent. They are 2008, 2013, and so on. So research is evolving. So you may, the reason you may miss that there is no strategy, national strategy, or strategy maybe the reason. So I expect that your literature should be at least within the last 5 years, if not possibly within the last 10 years. So yours is outdated. So I think that might be the reason that you say only 2% of the budget from the health sector is allocated for mental health. So if you review the recent data, you may change this number. So I advise you to revise your background. And the other one is the ethics issue. So I think it's important to consider the ethical considerations for patients. So I saw a picture that you want to not to show that his face. So I understand that he's not willing to pictures to his photo. So okay, you may take it as picture, but should not bring this, because it's evident that he is not willing to show that. So from ethics perspective, how you can address that. And for Tamrat, you studied in Ethiopia, but when you come here, you said studies from Ethiopia. So that's not appropriate. If you are comparing results from Ethiopia, you should mention the specific part of Ethiopia. And the other important point I perceive is that as your study is post-traumatic disorder, when you come here, it's important to compare with those who have post-traumatic disorder. That's important. And the last presenter, you said to explore the lived experience of their participants. So I expect quantitative study because explore is a term for given for qualitative. With the experience, it's a term given for a phenomenological study. So I expect that, but when you go to the presentation, there's a quantitative part, measure quantitative, and few quantitative. So your title should reflect the exact content of your presentation. I think that's very important. Even if you say it's a lived experience, you should dive detail and you may expose many unknown hidden truths about some. Thank you, sir.
Thank you, Mr. Representative. But to add on some issue, I still I get confused. The objective is to explore the lived experience of people who care for talents and was it feasible to have 800 something study participants to explore the lived experience? How was it feasible? I thought it was pure qualitative, but it came up with quantitative study and I'm saying adaptable versus non-adaptable. But you consider it as continuous. So how was it able to already categorize someone as the copy study as an adaptive and maladaptive? You categorize, but you told us that the outcome variable was considered as continuous. How was it feasible? Especially and the main issue is was it feasible to explore 800 something participants to assess the lived experience? And how do you get them? How do you get whether somebody has an experience on caring or not? So we feel that, yeah. So how was it feasible? The way matters.
Yes. Thank you, Sergey. Actually, I joined this session lately. I just presentation sessions. Basically, I shall comments forward by Professor Fernando and the participant. I am from social. The major comments are subject by there is methodological gap because there is mismatch between the topic and the method implemented by the lectures. The topic is the lived experiences of caregivers, so persons with living this problem. Since the focus of your study is exploring caregivers and lived experience, no question. The most appropriate method is phenomenological inquiry. No need of using other methods. No need of using research approach. Hence, there is methodological misgap. And not only you, I have seen articles published done by those contributors from health background observed some sort of distortions of applying qualitative research. In most cases, they claim to use qualitative approach, but they are not applying it properly. Even they are not clear about, but I am not making a generalization. Even they are not clear about the philosophical assumption of each qualitative research approach. Actually, I am not lecturing, but this is a learning platform. I want to share my experience. There are 5 types of qualitative approach: geographic, action research, phenomenological, and biographical research too. When we use each approach to investigate a certain problem, hence, which philosophical assumption guides your research in the case of applying phenomenology? Basically, it's a social constructivist approach. Hence, all these things should be understood clearly before applying a certain phenomenological inquiry. Qualitative research needs commitment. The process is very rigorous you didn't tell us the process that you followed from identifying the problem, selection of study participants. You say nothing about your fieldwork experience. You mentioned nothing about data management, how interview was conducted. You didn't tell us about the setting when the interview was carried out. You didn't tell us the feeling of study participants. You didn't mention the strategies that you employed in order to ensure trustworthiness of the data. This is very essential. How do we trust this data is very, very reliable, very, very reliable? How do you know engagement of data collectors and the supervisors in the fieldwork? Number of ethical issues may be raised. Hence, you may take it as a lesson. I was eager to hear the voices of caregivers, but you mentioned selected phrases. And so this is my critical comment. Others may take it seriously while applying it to the research approach. Don't use them for the sake of applying. Don't use them for a grant, okay? You have to be critical, okay?
Well, thank you very much. Yeah, for that matter, phenomenology should assess common experience of group of people who have an experience in common. But I don't think the lived experience of caregivers with schizophrenia would be similar with lived experience of people who care for depression or other mental disorders. So if we have to study lived experience, the experience itself should be common to all of the study participants. Maybe lived experience of people giving care to patients with schizophrenia or a specific mental disorder. Yeah, of course there are conceptual problems because we are very novice in qualitative research, especially as health professionals. It is only recently we are trying to include qualitative research into our studies. Otherwise, Chagga is an epidemiologist, and it is not easy for epidemiologists to do the right qualitative research.
I think, sorry for my interruption, qualitative is very used among epidemiologists.
Sure, now it is nowadays.
Anthropology and that.
Sure, epidemiologists usually follow positivism philosophy. They used to assume that there is single objective measurable reality. Now they understand now. Even Albert Einstein said that not all things that are countable count, and not every thing can be counted. So we can't count everything, and everything that we count doesn't make sense. So with this, we are now forcing our PhD students to do a mixed methods design.
There should be paradigm shift.
Sure, yeah.
Not express everything in numbers.
Yeah.
Words are also valuable.
Yes, yeah.
Particularly in their sector.
Sure. That is why Albert Einstein said, ሁሉም ነገር አይቆጠርም፣ በቁጥር የማይገለጹ ነገሮች አሉ። በቁጥር የሚገለጸው ነገር ሁሉ ደግሞ ስሜት ይሰጣል ማለት አይደለም። እና ሁለቱም ኮምባይን ማድረግ የተሻለ ይሆናል። ዴፊኒቲቭሊ ግን በትክክል ማወቅ ግን ያስፈልጋል። ኳሊቴቲቭ ሪሰርች ምንድነው፣ ከኳንቲቲቭ ላይ ምንድነው አድ የሚያደርገው የሚለውን ነገር ማወቅ ያስፈልጋል። ኤኒዌይስ ለእንትን ጥሩ ነው፣ አዝ ኤክስፖዠር ጥሩ ነው አሁን ባለው ደረጃ እንጂ ገና ብዙ የፒኤችዲ ተማሪዎችም እንግዲህ አንዳንዶች ታስታውሳላችሁ ባህር ዳር ዩኒቨርሲቲ የተወሰኑ ልጆች ፈትኝ ፌኖሜኖሎጂ ብለው they interviewed different people who didn't experience the phenomenon at all. እና ፌኖሜኖኑን መጀመሪያ ሳያውቁ መልቲፕል ፐርስፔክቲቭ ወስደው lived experience ብለው አቀርበው I rejected their ዲዘርቴሽን እና ያው በትክክል ኮንሰፕቱን ማወቅ ያስፈልጋል። ታንክ ፎር ዩር ኮመንትስ ኤኒባዲ ኤልስ ሶ if no more questions you can respond in the order you presented.
Thank you very much, Professor Tanaka. Thank you for your insightful constructive comment. Yeah, I should accept all the comments. That's just to reflect on some of the clarity issues. Yeah, I tried to incorporate a few qualitative results in 2 slides, but I agree that it is not well integrated. So, about the mental health strategy, yeah, we have the National Mental Health Strategy, which identified 5 core priority areas nationally. Yeah, I have seen that. Then I was looking the Ethiopian report on AIDS of WHO, which is presented for AIDS, yeah, in 2006. Yeah, so what I wanted to just incorporate here is it is a district level as per the scale of WHO assessment instrument for mental health system. It has one column that says mental health strategy, individualized, context-specific strategy. So the selected primary health care setting do not have, or they didn't have that kinds of strategy. That is what I would say. That nationally, yes, we do have. But when we say strategy, it is not like a strategical concept. It is defined as per the scale. Yeah, that is what I wanted to say. Regarding to the mixed method, yeah, it is explanatory mixed method. So we administered 3 established instruments. So we mostly used statistics. So our data, most of our data are quantitative, which is supported by quantitative data. So it is an explanatory design. Yeah.
Okay. Did you collect the quantitative data, analyze it, and after seeing the results, you continued with the qualitative?
Yeah, it is. We have a team, a group of research team. So we trained the data collectors, and first we collect the quantitative data, and then after a certain time, in phase 2, we collect the qualitative data practically by the researchers.
After analyzing the quantitative.
But we didn't finish the analysis.
That is the meaning of explanatory. Explanatory sequential design should start with the quantitative. After seeing the results of the quantitative, you go further to explain it with the qualitative. That is the meaning of explanatory.
Yes, so I should accept that. Yeah, so FGD interview, we have taken the FGD and interview. Here I try to mention the qualitative part, but I didn't present that. Sure, I should have done that. So we have taken 12 FGD in 12 areas, and then we have taken 26 interview. Until the data is saturated, we collected the data.
That means 1 FGD per setting.
Yeah.
Do you think that is enough? One FGD per setting or per facility?
Yeah, based on the resource that we have in our hand, we just tried that. But the response is like similar. After 2 hours of the discussion, we see that they repeat similar responses among the discussants. So we have taken that kinds of 8 up to 12 the participants were incorporated in each FGD. So
what was the maximum number?
12.
It is a range actually, but it is not recommended. As the number is higher, it will be diluted. It is likely to be more superficial. Usually, 6 to 8 is a reasonable number of FGD participants per group, I think. If you include 12, it will be very superficial.
Yeah, so this is it. Thank you for the other comments. Yeah, regarding to the reference issue, yeah, you are right. Yeah, we have to end nowadays thank you to epidemiologists and also other mental health researchers. We have recent data. Yeah, but for budgeting issue, yeah, I was trying to find the exact figure. Just to mention who said that, who found that, and then actually, but I just found 2% with reference, but in the different dialogues, I have here that 5% budget were allocated for mental health service and 95 for physical health service. Yeah, but yeah, I have here this is in the discussion, in the conference discussion, but I didn't find the difference for that. Yeah, so I will update. Yeah, you are right. Regarding to the picture, yeah, you are right. There is a picture protocol, and I didn't just pick this picture for this purpose. You can access in the internet this picture. I didn't. I just took the picture from the internet. So it is not for for privacy purpose. Yeah, the person may just raise his hand to cover his face. But if you Google it, you can find it. So I should take out that picture. Yeah. Thank you very much. Yeah. Thank you.
አጠር አድርጋችሁ take the comments as they are and only answer to specific questions.
Thank you, Professor and the other participants. I totally accept that Professor's comment. Traumatic exposure is preferable than experiencing the trauma. The second question was, don't compare study conducts in the same country. Actually, we can compare because the title post-traumatic stress disorder in exposing trauma event, and there was study conduct in at least landslide. So that was post-traumatic stress disorder and experience of landslide post-traumatic disorder. Not they are comparable. So I think I can compare my view. So,
Thank you for comments. I will take the comment as it is, but I will reflect on some points for the purpose of clarification. Our study was the quantitative and the qualitative. The quantitative was adaptive and maladaptive coping. There is no category in the first place. Our model was structural coping model. Adaptive can affect the maladaptive. Maladaptive again affect the adaptive. One affects the other. So it's not just a category. We took both as continuous, meaning adaptive has its own item, and also maladaptive has its own item too. So we take these items for each corresponding categories, and we took as a continuous. The other is on exploring particularly. The sample size was 620 for the quantitative, but in some conditions, the quantitative may not respond for some concerns. For example, the brief is mostly measures the situational and the dispositional coping. But in some conditions, like because of the experience they have, because of the behaviors of their family, they may have different or situational
copy. So in that case, this tool may not measure the situational. So in that case, we are going to measure more on with the qualitative one, lived experience they have. Was it they face a challenge, and what was the coping strategy they used during the situational or the behaviors they face while giving care to their family. The study setting was institutional, not community. It was conducted at University of Puerto Complex Specialized Hospital Psychiatric Clinic. The other is already the phenomenological, yes, it's phenomenological, we tried, but it is there. But we cannot talk more since because of the PowerPoint limitation. We try to mention in depth as we can. But lived experience of our professors, lived experience of schizophrenic patient care and depressive patient care is totally different. Which are the caregivers? Is there any difference in the quantitative one? Is there any difference among caregivers of schizophrenic patients and the depressive patients and other disorders? This is general, but there is no any difference in our quantitative analysis. So would you just consider that? Once the lived experience is different when gather what I did was the in-depth interview, which I did, and the experience was different actually, which gives an extra insight for the future recommendations, for particularly for doing the mixed method or the qualitative, since they have experiences particularly for the situational coping. Thank you.
Sorry for the interruption. The sense of employing mixed research approaches in order to see different needs of reality. The reality generated through quantitative approach and the reality generated through qualitative approach. We don't expect similar results from qualitative and quantitative. Just to see different perspectives upon the issues that we are exploring.
Yeah, sure. The quantitative is to get the in-depth information. But the quantitative one is just how much or how many of the study participants have adapted coping or not adapted. But once the in-depth of the information, we cannot just measure with the quantitative one. So that's why we are just using the qualitative for triangulating the quantitative.
You are not a criminologist, yeah? You know why we use quantitative study? You know it.
Yeah.
To generate idea, adala.
So it is
Yeah.
to see in-depth information.
So yeah, as you said, you as a lived experience and some of them, if they had and consider, if not, you use another methodology to assess. And would that make you?
What type of methodology?
Yeah.
Because
You asked them their lived experience, meaning that caregivers who came from with the client,
yeah.
What if the client was not as such experienced in caring the individual? When to say somebody has lived the experience, he might care for a week, the other might care him for 6 years or 7 years, but they came as facility. So the way you select the participant clear, and in the meantime, you ask the lived experience of 600 something. What was the relevant here? Because we assess lived experience to explore some variables, some insights. I have signed your mother alone. Just want to know you ask some lived experience.
No. The quantitative to measure the quantitative. To about 20, we need for. Sorry for the interruption. For clarity purpose, 6 months we have to sample size for quantitative, but we did interview for 20 study participants for quantitative.
Experience to the how to.
Yeah.
If that is the case, then why you present the quantitative time? And
I think we are running out of time, so we have to stop this session here. And thank you very much for your presentation.
So I think you may ask few question time, but there are presentation. So you may while we are setting up the presentation, you may see around. We are starting the next presentation now. So the next presentation will be done by Mr. Guru. So please be ready. The first presenter will be Mr. Getner, and his title is Prevalence of Depression and Associated Factors among the Positive Therapy hospitals in Amhara region, multiple crisis focus. Okay? And for room excess depression and dominance and depression, Sub-Saharan Africa systematic review, and to inform social reintegration strategies. So as he's being prepared, you may have to 1 or 2 minutes break there and we'll continue the presentation. Thank you.
Santanya apa? Presentante namanya? Ay, señor. Guru mantena? Failu stek. ለኔ ስጠኝ አሁን በእኛ ላፕቶፕ ይዘጋው ነበር።
እኛ ኮርስ አደረግን አያስፈልግም
አንተ መጀመሪያ ሁለተኛ እሺ ያንተን ትምህርት ነው ፕሬዘንቴሽን ሾርስ ነው ወይ ለኛ ደግሞ ውስጥ የሚያስፈልገው እነሱ እስከሚመጡ ደሱ አንዱ አለ የሚባለው ስልኩ አለ ሶስተኛ ፕሬዘንት የሚያቀርበው
መፈረም አለበት ተሳል እንትና ፈርማል ሰክሬታሪ
እዚህ ያለ ዶክመንት
In the interest of time, it's better to start. So, some of the participants may join us as their economy. So, Mr. Gettinger is going to present on the prevalence of depression and its associated factors in the categories within therapy, affiliated to hospitals in our region, Northwest Ethiopia, monitoring crisis focused. You have 15 minutes for presentation. And then, as a presenter, we continue as the previous presentation, and we'll discuss later.
ብዙ ነግታችሁ
Okay, good morning.
My name is Gefinlet. I am from the Roberts University. So our title is the prevalence of depression and its associated factors surrounding HIV positive users taking the ART at selected hospitals in Amara region. Okay. So these are the outlines. So this is this one. So depression is one of the most common neuropsychiatric complication of HIV/AIDS, and in turn it's associated with the worst HIV-related outcome. Is highly related with HIV outcomes. Currently, in circumstances of HIV/AIDS, depression is recognized as a global mental health challenge for HIV/ART users. So depression can lead to the thoughts of death and suicide, with confirmed 800,000 people deaths each year globally based on this reference. So depression is more prevalent among HIV youth, from 21 up to 50% compared with their peers, regardless of their mode of infection, congenital or behavioral. In sub-Saharan Africa, depression in young people with HIV is a major yet neglected public health problem, prompting more studies to screen and treat to improve HIV outcome. In Ethiopia, the limited access to a comprehensive HIV/AIDS mental health service remains a major challenge, efficiently combat depression in HIV-positive youth. So depression in HIV-positive youth has not been adequately investigated, especially in youth. So, however, this study conducted in Addis Ababa revealed depression 35.5 and 31.7 of HIV used in by these authors only in Addis Ababa. So sorry. Slide on. Okay, so these are the objectives. The first objective, the general objective, was to assess the prevalence, and the second is to determine the prevalence and the associated factors related with this depression. So the design, the period, and the area, so it was an institutional-based cross-sectional study, which was conducted from April to June 2023. The study area was selected for hospitals in Amhara region. The study and the source population was all HIV-positive users aged from 15 to 24 years, and those randomly selected during data collection period. And the sampling size and sampling procedure, systematic random sampling was used, and the sample size, calculated sample size was 460 users with ART. And the dependent variable, the depression, and dependent variables are the socio-demographic factors, caregiver-related factors, stressor or past traumatic events, behavioral factors, psychosocial support factors, and clinical factors. And the data quality, procedure, and quality was also maintained and validated, all these points. And the data processing and analysis also was assured. And when it comes to the sampling procedure, we took the 4 selected hospitals in Amara region, Injibara General Hospital, Funosalam General Hospital, Debre Marcos Comprehensive Specialized Hospital, and Palagayot Comprehensive and Specialized Hospital. And under each, we use proportional allocation sampling size. So we reach to all these 460 HIV use samples. So when it comes to the results, these are the social demographic results as it is displayed. And also these are the school dropout to HIV illness, yes to no, and so on, and residence, occupational status, household, all these factors were assessed. And these are the regression analysis. So based on our yeah, based on our final model, we found the associated factors were educational status and alcohol drinker, perceived stigma, WHO clinical stage 2, history of adverse drug reaction, and history of TB treatment were statistically significant. As you see here, yeah, I try to make highlight and bold educational status, alcohol drinker, and fail to school, that is term school, and stigma, and WHO clinical stage 2, and history of adverse reaction. And these are the factors which was found to be associated with depression, with use HIV ART on ART. So one third, almost one third, that is 30% of HIV positive youth suffering from depression. This is the main outcome from our study. In line with this result or finding, the study was conducted at Desi town and in Addis Ababa St. Paul's Hospital, also in St. Peter Hospital and Jimma town. All these results was in line with our study. And but this study was lower when it comes to the study in Addis Ababa, 35.5, Kenya, Uganda, and so on. And this study also higher than in a study conducted in Malawi, Nigeria, England, Thailand, and Ukraine, respectively. And also much higher than in studies in also another study in Desi, in Aksum, Debre Marcos also. So exposure to psychosocial stress and development were increased, depression in youth, but not in adults, what we as a conclusion. So what the difference was, it was due to study design, study settings, and even the sample size difference, and also the tool difference. So the study demonstrated a high prevalence of depression among the HIV youth according to the national youth health strategy. That's when it comes to the conclusion. So no formal education status and all this, the identified factors should be targeted. Scaling up the pediatric psychosocial support program to use psychosocial support for all ART site health facilities, strengthening health education about the medication, the adherence, and complication of HIV/AIDS, recruiting adherence supporter for all high-load ART site health facilities, and developing guidelines for psychosocial support for use are highly emphasized or should be incorporated. And HIV positive use with due attention, especially on no formal education, because the no formal education becomes significantly associated, and fail to school at terms, alcohol drinker, perceived stigma, to clinical stage 2, especially, and history of adverse drug reaction, and history of TB scale up pediatric psychosocial support, and adolescent, and all these tools, the program should be emphasized. Yeah, I think that's it. So I acknowledge the Debre Marcos University School of College of Medicine and Health Science, the Amara API, and study participants and co-authors. Thank you very much.
Okay, thank you so much, Jetinat, for this presentation. The next presenter will be okay. This presentation title is
Okay, thank you. My name is Gurum from University of Gondar, Department of Psychiatry. The topic what I'm going to present is depression and associated factors among the internal displaced population in Sub-Saharan Africa, which is a systematic review and analysis study. Okay. Okay. So this is a presentation outlines. So as background, internally displaced persons are people who have been forced to migrate from their homes to any location without crossing the international boundaries, which is different from the refuge. So, unlike refuge, IDPs have been remaining inside their homes rather than crossing the international boundary. So, in Sub-Saharan Africa, Africa countries experienced more internal displaced population than any other regions. This is maybe because of different unresolved and cyclical conflict combined with new waves of violence trigger. Therefore, the magnitude of sub-Saharan internal displacement is 3 times more common among the Middle East and even North Africa. These internally displaced populations may experience different types of mental illnesses. For instance, 1 in 3 people are affected by mental disorders. And from those individuals affected by mental disorders, more than 60%, which means 3 in 5 IDPs may have suffered from depression globally, which is studied by our Ethiopian scientist, which is a possibility in Australia. Furthermore, in sub-Saharan countries, the magnitude of depression is what across the countries are very inconsistent, which is the range within this range, 18.5% in Ethiopia to 94% in Kenya. Therefore, depression is what's very painful physical and mental symptom associated with mood fluctuations in people, and it has been identified as a form of unhappiness, worry, pessimism, and tension that makes it difficult to cope with daily day-to-day life activities. So, people experiencing depression may suffer from different psychosocial and physical problems. For instance, people experiencing depression may suffer or may be vulnerable to violence, and may suffer to vulnerable to suicidality. They may try to kill themselves because there becomes hopelessness. If you know the main component for patients with depression is what? Hopelessness and chronic impotence. Therefore, they may have what? Exposure to suicidal behavior. Even they have exposure to poor physical health problems, for example, like stroke and hypertension. And harm of health practice. Patients with mental illness, including depression, may expose to substance abuse. However, the overall magnitude or prevalence of depression among IDPs in this region, which means in Sub-Saharan Africa, is largely inconsistent and difficult to comprehend, difficult to conclude for decision makers. Therefore, this is very important to get the comprehensive data for decision makers. So, therefore, the main study or the main research question for this study is what is, there are 2 questions. One is, what is the full prevalence of depression among IDPs in Sub-Saharan Africa? And what are the full effect of factors associated with depression? These are the 2 main objectives of this study. Therefore, to get the primary studies, we have searched the PubMed, India's Science Direct, and Africa Regional online search engines were used to identify the relevant articles. A search strategy was developed for each database by using a combination of prefix and controlled vocabulary mesh. Therefore, 13 studies were included, which is among So therefore, this study was conducted among 8,383 IDPs and covered in 6 sub-Saharan African countries. Data were extracted by using Microsoft Excel spreadsheet and exported to Stata version 14 for analysis. The prevalence of depression or the main outcome is what assessed using the following 5 tools: patient health questionnaire, Hopkins symptom checklist version 25, common mental disorders, which is subsections for depression, mini international neuropsychiatric interview, and hospital anxiety depression scale and big depression inventory was used in the primary studies. The quality of the primary or the claim study was evaluated using the GBA quality appraisal criteria. The degree of heterogeneity was determined by using index of heterogeneity or square statistics. The studies on IDP in Sub-Saharan Africa, depression prevalence data, full data publication were included. Otherwise, those studies without access to the full data, example, some studies may have what posted their abstract only, and if this abstract was incomplete data or the required information is not yet, and and repeated steps were excluded. For the study, a random effect, their Simonian model, a random effect model was employed with 95 confidence intervals. For evaluating the publication bias, we use funnel plots analysis and eager distribution analysis. Therefore, we have observed the figures of the funnel plot as well as the regression tests to evaluate the publication biases. Since there is a high heterogeneity in our study, a subgroup analysis, sensitivity analysis, and meta-regression was done. For instance, a subgroup analysis based on the study settings, that means country, using the tools. Since as I've told you that 5 tools were used in the primary study, therefore a subgroup analysis based on the tools and the publications were done. About sensitivity analysis was also performed. However, there is no any significant effect. The removing or the dropping of one study has no significant impact on the overall prevalence of the meta-analysis. And we have also done the meta-regression analysis in order to find the source of the heterogeneity. Therefore, the meta-regression analysis was done based on some covariances using the tools, that means the tool size, the sample sizes, the publication year, and the study settings, the country. However, there is no neither of the covariances were found to be associated with full prevalences. Regarding the full prevalence of depression, of this meta-analysis, it's found that 64%. This finding is consistent with the global prevalence rate of depression, which resulted 60%. On the contrary, the current finding was significantly higher than studies done in the Ukraine IDP, Sri Lanka, and southeastern Pakistan, Iraq, and Georgia. Therefore, there may be what the variation of the prevalence across with this study and my studies, what maybe the variation may result from the socio-economic gaps between those countries and Sub-Saharan Africa to fulfill the needs of the IDP. For example, the majority of Sub-Saharan countries have scarce financial resources to supply food and basic services for IDP. The national treatment of neglect to make sufficient provisions for addressing people's mental health requirements, including in IDP. Regarding the second outcomes, that means factors associated with prevalence, female sex have been about 2.7 more odds of having depression than males. This finding is in line with the global study. This may be in the displacement settlement, women face special challenges like conflict-related sexual violence, unexpected pregnancies, gender-based, that's gender obligation to care for the children, the elderly in the IDP camp. Therefore, all these, the over what responsibility may stress the females than the male, which what stressed and becomes what develop depression. Another factor is what non-partner sexual partner, which means either separated, divorced, widowed, or widowed. Therefore, such types of marital status people have more than 3 times the likelihood of depression than their counterparts. Therefore, this is supported by studies in Colombian IDP. Being separated or divorced, as well as losing their sexual partner, may result in lack of social support, turning them into what widow or single parent in the IDP, which is what associated with stress and depression. And the prevalence of depression was more than 2 times more common among people who have experienced stressful traumatic life events. For example, traumatic life events that associate like illness without access to medical care, lack of or insufficient of food, water, and such like traumatic life experience may have report more depression than their counterpart. So traumatic events such as illness without access to medical care, lack of food and water, and being beaten or tortured, especially in some countries, have been significant impact and worsen a person's mental health status, including depression. And finally, depression was 2.7 more prevalent IDPs who have history of death of family member in the IDP camp. If they may lose their family members in their due to their displacement, they have reported more depression than the counterparts. Therefore, this was supported a study conducted in Pakistan as well. So it has been noted that the loss of close family member was loss of vital social supporters, which record to cope the displacement as well as the significant distress in the IDP campus, which was for depression. As conclusion and recommendation, this systematic review and meta-analysis found that a high pooled prevalence of depression among the IDPs in Sub-Saharan Africa. So depression was significantly associated with being female, having a non-partnered marital status, those who have experienced traumatic life events like being inaccessible of food and water, and illness without medical illness without any access of medical care, and those who have lost their family member during displacement. Therefore, these findings highlight a substantial mental health burden faced by a displaced population in the region. Therefore, the following actions are recommended. Integrating mental health screening and social support into primary health care and humanitarian service in order to, in the IDP settings, which is very important to screening early those screening individuals, especially the vulnerable population. Develop targeted intervention for high risk groups, particularly women and individuals with trauma history, including those who have experienced violence and severe deprivations. Strengthening multi-sectoral organization between the government, the NGOs, and other humanitarian agencies in order to access the food, water, and adequate shelter and psychosocial services. Promote cultural sensitive and community-based mental health programs such as trauma-informed care tailored to the specific needs for IDP in Sub-Saharan Africa. And future researches is better to do focus on the linked transfers, how depression among IDPs have evolved over time, particularly in the early integration and the resettlement time. Thank you. I would like to acknowledge for the authors of the included primary articles, as they help us ground for this thematic meta-analysis, and I also thank you for the IPH, the University Forum of Amara region, and thank you all.
Thank you. Thank you for your nice presentation. So, in the interest of time, now and to make the discussion easier. So, Andrea, so let's attend to his presentation. His presentation title is Predicting the Malnutrition from the Ethiopia. So, to save time, to use our time wisely, let's hear and then we'll make the discussion. Thank you.
Good morning, respected audience. Thank you for to present our work, which is prediction learning. I'm Alan, now from the university, which is mathematical informatics. BSc in informatics and also others of reason is data science. And the title, which is the predicting malnutrition in people living with HIV, living in Gondar, which is a machine learning approach to predict the risk of malnutrition in HIV patients. As a presentation outline, as shown in this background, objectives, the method, result discussion, conclusion, recommendation, and so the last which acknowledgement. As a background, the information of HIV, which is as present the previous or the yesterday sessions, which is shows also HIV affecting the prevalence as a global 39.9 million at a global and using 67 within Sahara, and malnutrition worst HIV outcomes also, which is the concern to in HIV/AIDS and malnutrition prevalence among the people within HIV in Ethiopia, which is in the range of 23 up to 50%. So as the study shows, and HIV, which is recommended by HIV, nutrition is recommended by WHO to integrate this service in HIV patients at home. So the prevalence of malnutrition among people living with HIV in Ethiopia is high, and MR data under the trials for predictive analytics. Now the Ethiopian MR system integrate start or use the MR system for HIV patients. So that data is under the trials for predictive analytics. So now prior machine learning needed all techniques are not applied in malnutrition predictions of HIV previously. Early detection is critical for timely intervention and resource planning, as the study shows. So we should predict based on our historical data, and we use to show or to predict the future or gain the patterns and insights from the data. As the objective of this title, which is to assess the nutritional status of people living with HIV and predict the risk of malnutrition among the people with HIV. As the study methods, study design, which is institution-based cross-sectional study from University of Gondar, MR system, and study population, which is around 4,152 people living with HIV, and the outcome, which is the nutritional status, is the outcome variables, and predictors, which is socio-demographic characteristics, clinical, hematological, immunological, and also treatment-related factors are included as a predictors of this study. As a machine learning pipelines, as diagram show, which is the data source from the map system or ARC screen, and data processing in machine learning also happen. And the data is extracted from MR database, so that data was extracted and exported into CSV, and also data processing and cleaning is done by using Python program, which is a version of 3.12, and feature engineering and the dimensional reduction of the features from the list of predictors, and balancing of data is unbalanced plus, so balancing of the performance on data pre-processing on machine learning. And process data also was split into training and testing data, and 85% of the data was for training purpose and 20% for the models, which is selected finally for the best models. So model groupings apply 8 machine learning models special logistic regression, decision tree, support vector machine, equinox, neighbors, and random forest, gradient boosting, neighbors, and executives. The models was applied in this experiment. And the model viewed and also the tests and model one, which is based on the evaluation matrix, precisions, accuracy, recall in the form score, and also area under the curve UC, which is all model are evaluated based on this and select the best model which is outperformed from the experiment. As a result, which is some of quantitative parts, which is socio-demographic characteristics and also the future importance. So, as the future importance, which is we use more than 20 predictors to learn in this machine learning, and the top predictor, which is the duration on ARP, imagines age, the recently CD4 counts and baseline CD4 counts, which is the top the predictors from the machine learning. So, as shown, this social demographic characteristics, nutritional status, so the normal, which is 62.8% and overweight is like this numbers of the result as shown. So, as the model performance, which is outperform the top four models, which is support vector machine, which is outperform the accuracy 80.1%, the precision 8.4, recall 8.1, and influence 17.5, and also AUC, which is 0.8%, which is the top of the machine learning result or the predictors one. So, superior performance of this which is support vector machine models achieved, which is 0.92 versus which is the previous study from 0.60 to 0.75, which is the highest perform in this machine learning models. And the top predictors identified by SHAP analysis. SHAP analysis can show the hidden patterns or the relations of each predictors and outperform, which is the three of the top predictors by SHAP analysis, which is ART duration. Longer duration is predictive and reflecting the data that has stability as shown in the SHAP analysis. And BMI, which is a predictor, directly measures nutritional status of the screening and also the treatment adherence. This is the poor adherence when outcome highlight need for the supporters, and the SHAP predictors are these are the top three. As a conclusion, machine learning models is particularly supported machine, which is based model, are effective and robust for predicting malnutrition risk among people living in Asia. So, the model identifies this the top predictor, which is ART duration, BMI, and treatment adherence has the most influential. The predictors of nutritional status based on SHAP analysis has concluded our study. And as a conclusion, and the recommendation part, which is integrated machine learning based tools into routine HIV care to support the early identification and malnutrition. Because we have already have the system, which is AMR system, so that AMR system should integrate this model to the early identification of the malnutrition, which is a comorbidity for HIV patients, one of the comorbidity. So it should be identified early and it should be integrated and highlight. So if we integrate on that, it should be notified each person or each client to be needs support, and it's flagged within some of notifications in the systems. And also improve AMR documentations and include rich clinical features in AMR system, which are lacked in the previous study or using our study. We cannot get this awareness make use of information. Data and also marks are entered the MR system. So the MR system should also enhance these data entry documentations to enhance model accuracy and determinism. So it will improve the knowledge, which is the system developers from the MR system, which is supporting the reality of the MR system. And also, as a government in the policy, it should be also invest in storage infrastructure and capacity building this also to implement these innovations and technologies they need to enable machine learning integration in clinical work. Not only this is machine learning only, but also it needs the artificial intelligence nowadays. So it needs high levels of now the Ministry of Health, which is line which is the policy in digitalizations. So it should be integrated and it should also invest on this and capacity building more of clinicians and also experts to generate insights from these huge numbers of data. We have is the era of which is the lake of data. There is the era of big data. In big data, which is the era which is the lake. The previous date, which is we have a data warehouse. Now we have data lakes. So which is the shifting of the data and to build up the current model using additional data for researchers to implement this model. They build up the current model using additional data and test applicability across regions in the population to address the, this research gap, which is have only use one center and one step, so it should be incorporated. And some of maybe generalizability issue, more of the populations are using urban, which is as you can read the text, which is 76.5% are urban the population. So the generalizability it should be answered by the researchers to the future. So the task is to the future. And acknowledgements in the last, which is University of London, specialized hospital, and also particularly medical doctors who do this data collection, research collaboration with others, and also which is on the list, which is APHI. Thanks all of you, and thanks.
So I think it's time for discussion. So let's give the audience a chance first, and we will directly our speaker. Anyone interested to comment and ask questions or provide feedback? Possible.
Okay, this is a nice question. I'd like to thank all of the presenters. They raised very interesting and national and international concepts. My question is just the issue of displacement and consequences of displacement. Diversified, including military problems, also including in our country for different reasons, maybe conflict, war, and maybe because of development-induced poverty, millions of people are experiencing internal displacement, and also suffering from mental health. My My question is, okay, it is related to the materials that you reviewed. I know that Agile is widely circulated, it is accessible, but it is not indexed. What do you say? And because there are comments regarding some of publications do not be passing through critical review, why you consider Agile? Another question, under your recommendation section, you suggested the need to practice policy-based mental health in the context of African countries. There are diversified cultures, values, norms, and socio-economic diversities. For example, which culturally appropriate practice will be suggested in the context of Ethiopia and in the context of West African countries, and there are also Central African countries, where there is a cultural diversity. Thank you.
Thanks so much. Any other questions? So let me reflect on my so the first one go to state participants use how do we do so how do we do and the other one is you study systematically which so you study last date of search was 27 April 2020. So this is very it's your then review if your last date is 2017, now we are in 2015. So if any researcher, any systematically run activity, if it is longer than 1 year, there is a need for active research. So we expect an active research. So if you want to maybe communicate with stakeholders in a similar scenario, you may consider updating your research. So that's good if it's published, but if it's not published, then we ask. And even if it's good, that's so in this case, you may consider even updatable. That means updated search versus updatable. If the systematic review is not published and if it's more than 1 year, you need to conduct update search. However, if it is published and if you think that it is relevant and continue working with that, and if the publication 2 years from that, you may consider. Otherwise, in addition, it's not that you include other we ask that you consider the main basic data asset database, but I also have additional questions. You consider And the other point is we use different articles you included, they use different tools to measure difference. So I may say that they are not homogeneous. We use five or six tools. Yeah. So is there any evidence that those 5 or 6 tools measure similarly? Because if that's the case, there might be heterogeneity. So heterogeneity can be described in relation to statistical cases, but we may describe in relation to tools or study design. That's important to know. And in addition, what was the study design of those included studies to ensure homogeneity? And last one, in practice, in real practice, if we have the abstract only, for example, someone may get your abstract poster on the web page, and if we feel that this is very important for our review, we will contact the authors to get the full papers or any additional data. So you consider contacting the authors before rejecting or executing those abstract on first. Okay. I think for Andalan, it's interesting, another interesting research. And my question comes to my mind is are we ready for such services? Maybe the investment is huge. Yeah, I know there's a national strategy dialogue scale. So the investment, how do you comment on that? You just say it because the investment, it needs huge investment. I know that for our institution, for our university, Bhakra University, it's huge budget for digital. So are other institutions are they really committed? Are they really capable? So I think it's good to know your view on that since we are doing research. And is it really accessible for remote areas?
Okay, thank you. Many of the issue has been raised. The first presenter, the title is in Amara region. Yeah. So how do you select the hospital? And I found them in West Amara and in major cities. So how did you get the study sites? Was it randomly listing all the hospitals like in Samara region and randomly select or was it West Amara study and then I need to know genuinely how you select for study areas, study hospitals. How many were the total cases in your study area? Could you tell me how many users were users didn't use it? How many were they? What is the original report? And what was your rationale to go into the four hospitals? And you acknowledge co-authors. They were not involved in research. You acknowledge the co-authors, yeah? Why? They were the researchers themselves. Why you acknowledge them? That was the second presenter. You come up with a very nice research finding. And the food was higher, yeah, than the local area. But in the meantime, you are comparing with single studies. You come up with a full estimate and then you compare with single studies. What is the difference for you to compare? And it would have been good if you show us how was heterogeneity, how wide was the confidence interval. But you told us, you know what, I'm not sure whether what you told us is real. Because I would be very happy. Otherwise, I'm not sure if it was so that we could learn. Otherwise, I would.
በዚህ ላይ ፕሬዘንቴሽን ላይ አይታወቅም። ሶሪ ፎር ኢንተራፕሽን እዚህ ጉግል ላይ እያየሁ ነው ዲስከስ እያደረግን
ነው እንግዲህ አሁን እዚህ ጋር ምን እንዳለ አላውቅም። ኦንላይን አልመሰለኝም ግን any way of assessing nutrition, I'm so happy. It's a new era. Yeah, machine learning is not becoming common. I have no any exposure actually, and the ordinary assessment. But in the rational machine learning is very horizontal. People living in the child, I mean, so the kids, adolescent, and adult, and the period of target because you use BMI, and I thought for children for lower than BMI now, how the machine will be taking, you know, normal, overweight, underweight, and obese. Yeah. The example category of machine.
Full text file,
So you consider
secondary
25% will change or more
limitation
so the information was found high. Did you recommend us to use that or still the other finding might come with another finding but the situation was protective, right? The more we know that when people are living with the child with medication, there are other physiological changes, and then the BMI would be much better, I don't know. Because as you know, protective only functional lasting, there are confounders in it.
So much, I think you're not going to have one.
Thank you very much for your you have told us BMI is identified as around age and assessment for people with nutrition status. Industry, you cannot use. BMI, considering that BMI, considering that positive one is active, industry are going to use this tool just to predict chemistry participants. And the last one is to include one. I think the most advantage of using
Suggestions of this. I think it's better to take the comments and suggestions, comment, and to later just so you maybe you may start taking stuff and you may be something else.
Okay, thank you, Chairman, and also Sayed and Sri and Abbab, yes. So, of yours is an or that is the pediatrics. As you know, the use from 15 to 24 years. So, how do you living our that is the study at the selected hospitals of the child of yours from our baseline of these two on the straight line. So and our living distance still currently. So that's the reason. But we can revise as Western Amara or Eastern Amara. Yeah. Yes.
So you mean generalize for us?
Yeah. On the selected hospitals. That means Jivara Hospital, Hospital, Pelagios hospitals. We can, the researcher can stand on his the selected hospitals to be from all. There was 1,258 ወይም 1258 ዩዝስ አግኝተናል። ለእነሱ ነው እንትን ያለው ማለት ነው። ዘን ፕሮፖርሽናል ሎኬሽን ሰራ። I think that is my response. Yeah.
Select permanently. If the selection is for other hospitals, that's the point.
Yeah.
These Hassans have been to the that's the key to the information. You see that we can use chapter and you can government to this information or the realize it
I think WHO Islamic standard use the
no generally African chapter
from crossing structure outside of cross section. This is shit. Cross section. So what is the ራቹት የት ላይ ነው? ሆስፒታል ብቻ ማለት ስድስት የተለያዩ እኛ ሆስፒታል ብቻ ነው ለተለየ ስፔሲፊክ ለሆነ ፕሮጀክት ያንሳል ማለት ለሆነ ያን ፕሮብለም ካገኘ በኋላ
you have to start. Automatically, usually, advise conduct finals. So, when you get an investor, really, I need
I think thank you so much. Thank you. Some questions I found out. Some